Hello, may I present Polycystic Ovarian Syndrome. I'm Dr. Anil Gudi. With Dr. Amit Shah, we are both consultants in reproductive medicine at Fertility Plus. The diagnosis of polycystic ovaries requires two of the three criteria. There should be no ovulation, there should be high androgens, or there should be polycystic ovaries on a scan. When you come to anovulation, what are irregular cycles? Periods more than 35 days, less than 6 periods a year, or no periods for over 6 months. The next is hirsutism, which is male type of hair growth. You see that with acne, oily skin, and hair growth. What are the investigations? The FSH test, the LH test, the estradiol test, the anti-Müllerian hormone, DHEA, DHEAS, testosterone test, and 17-hydroxyprogesterone. With ultrasound, an ultrasound scan should detect more than 12 antral follicles as seen on the picture to diagnose polycystic ovaries. Now 17 to 33% of the normal population will have ovaries that look polycystic. What symptoms do we see of polycystic ovaries? Menstrual disturbances, hirsutism, acne, infertility, obesity. Now this occurs not in a very fixed manner and can vary from person to person, as you can see in the percentages. Before we try any treatment, we will need to check the tubes. You can either do it under ultrasound called the HICOSI, or do a hysterosalpingogram, which is an X-ray based test. What treatment do we give? The first is CLOMID or CLOMIPHENE. Maximum of 6 cycles, given from day 2 to day 6 or day 5 to day 9. Maximum dose is 150, and about 75% pregnancies occur in the first 3 cycles. Why is that CLOMIPHENE fails? Why there's ovulation but no conception? Probably due to the anti-estrogenic effect, and in those cases CLOMID should not be given. The other drug is metformin. It is a diabetic drug that does work in some cases of polycystic ovaries, but to a large extent has been abandoned, and this should be used only with a consultant approval. What are the options if CLOMID fails? Option 1 is to carry out ovarian diathermy. The second option is FSH injections, and the third option is IVF. What are the different FSH injections? There are multiple names. They very much do the same thing. They're called Gonalef, Marinol, Fostimon, Menopur, and Puragon. Their ingredient is FSH. How do we give FSH injections? The traditional method is to give 75 international units daily with regular scans. Second or preferred option is the low dose option of starting with 37.5 or 50 as a daily dose, which is a far better option. How do you give these injections? We do a scan, which is arranged from day 1 to 3, and repeat scans every 2 to 3 days to see if the follicles are growing. If you see the scan, what we want is a couple of dominant follicles, 1, maximum 2. You see smaller follicles which will be growing. These follicles need to reach a size of 17 to 20 millimeter before ovulation. Trigger injection is the most important aspect of achieving ovulation. It replicates the LH surge And this can be given, it's either an Ovitriol pen or a Gonasi injection. Once the injection is given, ovulation occurs in 36 to 37 hours. What are the complications? The first complication is that your PCO ovary has so many follicles that you may not respond at all, and they are resistant. Or they may have an over-response where just too many follicles may grow and the cycle may need to be cancelled. In summary, a low-dose gonadotrophin should always be used if CLOMIPHENE fails. Metformin may be added in a few cases. Testing of tubes is essential and normal sperm count is essential. What other treatments can you use? You can use ovarian drilling or you can attempt IVF. Ovarian drilling is done by laparoscopy and 4 holes are burnt under vision. This may initiate ovulation by lowering the androgen levels and is often used if CLOMIPHENE fails to start ovulation and if the couple do not want to try injections. Now, the last treatment is IVF treatment for polycystic ovarian syndrome. There are certain challenges which we will shortly discuss. What are the challenges? We may have just too many follicles. Ovarian hyperstimulation syndrome may occur. Many eggs may be abnormal, which are immature. And sometimes womb lining goes out of sync and pregnancy rates may be substantially lower. Now, there are newer protocols for IVF in polycystic ovarian syndrome. The low-dose protocol, a very close monitoring to check for response, giving a GnRH analog trigger supercure, we give natural LH, reduces the rate of ovarian hyperstimulation, and freezing of embryos. All these are helpful. In PCOS, embryo freezing has revolutionized the way we treat PCO. It allows the endometrium, the lining, to go back to normal and become more receptive. 10 to 15% higher pregnancy rates can be achieved for younger women by this technique. Thank you for listening. I'm glad you have enjoyed this presentation. Please contact us if you want to discuss more for an appointment on 0800 022 6038. Thank you very much.